Welcome to the Connecting Transportation and Health, a guide to communication and collaboration concurrent session. I'm Carrie Draper, a senior research associate in the Arnold School of Public Health at the University of South Carolina. There, one of the things I do is lead a SNAP-Ed implementing agency. SNAP-Ed is a United States Department of Agriculture Nutrition Assistance Program. The program model includes delivering direct nutrition education in a wide range of settings, working with partners to change policy, systems, and environments to make healthy eating and physical activity more accessible and equitable, and implementing social marketing campaigns. Recognizing the vast barriers and disparities that many South Carolinians face with having reliable access to transportation, our SNAP-Ed team is working with local food policy councils around the state to strengthen and expand transportation options for people living on a low income. Oftentimes, municipalities place more emphasis on our roadways for car drivers than those who cycle or walk. And healthcare and other community resources are located on cheap land without transit service or even pathways. Having farmers markets, grocery stores, healthcare services, and other helpful community resources is great. But what if those who really need to take advantage of them can't get there? That is what you are going to learn about in today's session. Today's speaker is Stephen Yaffe, proprietor of Yaffe Mobility Consulting, and he's going to tell us how to better plan transportation with community health in mind. I hope you enjoy this session.
And the Connecting Transportation and Health. I'm a transit consultant. I'm active in research with the Transportation Research Board. I'm an Easter Seals contractor with the National Aging and Disability Transportation Center. I'm also a road cyclist and the human behind two ambling dogs who may be interrupting, but hopefully not. But today I'm speaking with you as an ambassador for a reference document useful for advocates and for planners, Connecting Transportation and Health, a guide to communication and collaboration, referred to as a communications guide. And the idea behind this guide is partnerships. I've found throughout my career, nothing that lasts and nothing is fully beneficial to the community unless it's developed in terms of partnerships, through partnerships. So this guide will help facilitate partnerships among health and transportation advocates and professionals, because we need these partnerships to produce projects that benefit the whole community, not just car drivers. So I'm here to share the communications guide. I'm speaking on behalf of the TRB Committee for Transportation and Public Health. I'm here to invite you to join me as an ambassador of transportation and public health, and to please share this important resource with others and for those of you who work in public health. And third, I'm going to invite you to join another group called ipathinc.org. That's the website. IPATH is the International Professional Association for Transport and Health. And we're developing another guidebook, this one offering joint metrics to measure success. You can always download information on this guidebook through the website trbhealth.org. That's TRB, Transportation Research Board, trbhealth.org. And I have to say, this research was funded by the National Cooperative Highway Research Program and the American Association of State Highway and Transportation Officials, the AASHTO Committee for Environment and Sustainability. And you saw 105, task 105, because this was a 105th document produced for this committee. Again, please share the guidebook with colleagues in meetings and presentations. Together, we can amplify the message of collaboration between transportation and public health. Let's go to the next slide. So the guidebook was prepared for the committee that I identified. This slide identifies the people who wrote it. As we all know, it's helpful to understand where your information is coming from. So this credit slide includes the primary authors. It does not include a big team of collaborators, including the technical working group. But you can see that This guide had extensive state and federal Department of Transportation involvement across the country. Next slide. So why was this guidebook developed? And you can see from the screen, we had three basic goals: to build on best practices for transportation health collaboration, to create an accessible communications guidebook ready for practitioners, and to provide resources to afford effective communications for advocates, a whole bunch of people. It's got enough detail to support communication with public health and transportation agencies and stakeholders. We're working to avoid the jargon and bridge differing perspectives as well as communications approaches. And they are very different between transportation and public health professionals. So the tools and resources from the guidebook are also available separately. They include a quick reference guide to support outreach and communications efforts. The guidebook can be used as intended to be used, both by transport and health agencies who already coordinate, as well as agencies newly reaching out. Those studying the transportation planning process can use this as a reference. It's not dense. You'll find very clear sections that are easy to skim for information and relevant examples. Next slide. So the research products out of this, this slide shows the cover of the guidebook and lists the supporting companion materials. Everything is available on the webpage at the bottom of the slide, which is hard to remember. Just keep in mind trbhealth.org. That's a shortcut that can get you to this link. So, the products include the guidebook and tools, the overview presentation, slides, a speaker notes, a summary brochure, and a summary report. Next slide. Transportation and health has key intersections because we have overlapping interests and we have overlapping goals. And you can see the key categories where they intersect in the middle, where it's in bold. These include safety and injury prevention, physical activity and active transportation, air quality, connectivity and access, evacuation and emergency response, and equity. The differences between transportation and health perspectives are reviewed to identify opportunities and needs for communications. You can also look up the Federal Highway Administration's Health in Transportation Objectives, as that also discusses the intersections between transportation and health, as does iPathInc.org. So if you looked at FHWA, Health in Transportation Objectives, you'll find a lot of good materials. Next slide. This guide is also helpful because it maps out both transportation and health processes. Processes are important to know. And it suggests milestones where these perspectives would inform each other. The transportation process is linear. I could go into detail. The short summary is policy, plan, program, and project, but there is a 4-step planning process, which is also linear. Public health, not so linear. Public health initiatives are delivered through a combination of public, private, and nonprofit entities. And this slide shows some of the more common public health programs and initiatives, each of these initiatives can and should connect to transportation. Transportation policies, plans, and projects can be shaped by both the health in all policies approach. I'll repeat that because that's an actual term, health in all policies, as well as health impact assessments. Community health needs assessments, CHNAs, and improvement plans provide useful health data, needs, and goals that can be used in transportation planning. Project and public health campaigns involving transportation rely upon communication between transportation and health stakeholders. So the resources within the section include common health, public health goals in the middle, more details on the steps of the health process is shown on the left, and case studies of communication and collaboration opportunities as shown on the right. So there's some examples on the right Well, let me go into a few on the left. The second one, community health needs assessments, CHNAs. They're required by every nonprofit hospital every 3 years. That's part of the Affordable Care Act. They're supposed to assess the needs of the community, all sectors of the community, how what the trends are, what's most acute, how they can meet those needs. Can they get the healthcare or the counseling or for mental health, nutrition, whatever it happens to be at the hospital or associated facilities? Is transportation a problem? What I'm dissatisfied with CHNAs is they don't specify the methodology, especially on transportation, nearly enough. There's a few that do get into the data. Johns Hopkins has a good CHNA, and I'll start with a G. There's a hospital out of Atlanta, public hospital, nonprofit hospital complex that has a good one too. Because healthcare is kind of useless if you can't get to the appointment. And I'm a transit professional, so that's what I do. I'm going to give you an example of an infrastructure project. I live in York County. I'm a member of the Bike Ped Coalition of York County. And we advised on a interchange design. Highway 160 is being rebuilt over I-77. It's time to rebuild it physically, but it has a capacity issue. South Carolina DOT came up with 3 alternatives. We looked at the alternatives. The most expensive one is the most functional for vehicle throughput, but one would almost have needed a zip wire to walk across I-77 with their initiative. So we suggested you've got a median on 160, crosses the span from one traffic light to another with I-77 in between. Don't waste the median, make it a pathway for cycling and walking. And that's what we expect that they'll do. It's on their preferred alternative. Makes a huge difference because I've seen people try to walk that interchange now. And we need to be accessible. A lot of people don't have access to a car. So next slide is gets into what does transportation and health collaboration look like. And this shows real world examples of what transportation and health collaboration would look like. Safe routes to school, increased physical activity, planning organizations integrating health impacts into plans and project selection. We've got tools, car sheet checks, walk and wheeling cooperative audits for pedestrian accessibility. And you can actually download some material from that from AARP livable communities to do walk audits. And health access studies. Again, healthcare is useless if you don't have a ride. So you're viewing the slide from all over South Carolina. Every community has adults who don't drive, either due to disability or affordability. So how do they travel to health destinations? Health destinations is not just the doctor's office. Health destinations include stores that sell produce, rec centers with exercise equipment. These are just 2 examples of social determinants of health. I already talked about the CHNA. It's your local planning organization has the tools to assist a nonprofit hospital produce a community health needs assessment using planning tools that show whether those in low-income communities who don't drive can reach the medical offices in that hospital. I'll give an example. If you go to nadtc.org and look at diversity resources, because we have a diversity initiative going on, you'll see a tool near the bottom from Delaware where they use census block data and GIS technology, geographic information systems technology, to do such an analysis. They can apply a modal overlay. You can do transit or bikeways or what each mode individually, and compare the travel time from low-income neighborhoods as opposed to middle or high-income neighborhoods, or from minority neighborhoods as opposed to white neighborhoods, to get to lower wage jobs, industrial or warehouse zoned census blocks, to grocery stores with produce. Dollar store is not a grocery store that sells produce. And we have a lot of food deserts in South Carolina. To post-secondary education, so that one can improve one's skills, to community centers, to access community life. You can measure the equity. Equity is measurable. And this is, the tools are available for planning organizations to do that. Next slide. Whoops, I'm going a little bit too fast. Okay. Again, for more information, you see the big long link at the bottom. You see the shorter link on the right side to both trbhealth.org and ipathinc.org. I'm hoping that I inspired you to learn more about the guide and the message, because I want to ask each of you to commit to take 2 actions over the next month or so. I want you to visit the webpage and scroll through the guide and identify at least one way that you can apply a lesson from this guide. And once you do that, have a conversation about collaboration between health and transportation advocates and planners in your community. You could do this at meetings with your friends, at forums that, as we are getting inoculated, we can go back to. Plus, a lot of them can be outside. Lots of opportunities. And if performance measures are your interest, IPATH needs members from a variety of perspectives to review draft chapters of our upcoming metrics guidebook. And IPATH has a virtual conference coming up in June if you are interested. So I ran through this probably a little too quick. Why don't I give you a few other backgrounds on, again, my perspective is transit, but I walk and I cycle. Every transit trip is multimodal. Nobody floats to a bus stop. People walk there mostly. In South Carolina, we seem to really love our pipe stem developments, which has an entrance off a collector road, and that maybe only one. And then each neighborhood is separated by a moat or whatever. Drainage is an issue, I know. But it makes it hard to extend transit service in some areas. So some towns, Wilson, North Carolina actually is the biggest one near here, have gone to another system. They call it microtransit. It's demand response. They use GIS to create an invisible fence around an area and have the vehicles bop around within that. And that's flexible, but it's inefficient if you have to go to each individual address. Their provider is VIA. VIA's concept is we'll have you meet at central neighborhood meeting points that you can walk to. That helps too. But if your neighborhood is just a little pipe stem, it's still inefficient. Vehicle has to go into the pipe stem, out of the pipe stem. Wouldn't it be good if we could advocate for pathways along collector roads and arterial roads, continuous pathways, so that we can walk off our Bojangles and we can go to a meeting point to meet a bus or a smaller vehicle, so that we can have transit service in some areas that don't have it. I should also note that the trend in transit is, in general, if you're in a bigger city, is to concentrate fixed route service, bus, or those areas that have trains, to run every 15 minutes or better, all day, every day, 18-hour spans at least, because those routes are connecting higher intensity land uses, commercial, office, residential. That leaves out the lower intensity land uses. That's where that microtransit comes in, demand response, picking people up, bringing people to a transit hub. Someplace near a diner would be good, or a 7-Eleven, other convenience store, where people are around anyway. It has to be accessible protected crosswalks, the whole 9 yards, place to park your bike or your scooter if you're brave enough to do those things. And eventually we're going to have a fair platform to pay for it. One app to book, to learn how you can get from one place to another, to book your rides, to pay for your rides. And then that app will do the reporting if your ride is subsidized. Another concept, while I've got time, is the mobility wallet. In the introduction, they mentioned SNAP cards. Every state and every Native American reservation in the US offers individual account-based electronic balance transfer cards, EBT cards. Every SNAP card is such a card. Money's loaded once a month. You can spend it at participating stores, but not on Cheetos. We can do that. We have a few examples of that in transportation. Everybody gets an account. You can add money at 7-Eleven or draw it down from your checking account. And you can, if you ride often enough, you get a subsidy. You qualify for a monthly subsidy so that you don't spend too much on transportation. If you have Medicaid transportation benefits, they could be downloaded in this scenario. There's 130 federal programs that subsidize rides, more at the state and local level. We can make this efficient, and we can offer access to healthcare and other locations for those who don't drive. I hope you've been typing in lots of questions because I'm ready for you. Hope this has been helpful. Thank you.
Thank you so much. This has been helpful. This is Meg Stanley with Eat Smart, Move More. I don't see any questions popping up yet, but if those of you who are attending would like to submit questions, please use your Q&A chat, and I will be able to see them come through and be able to ask our presenter and forward those questions on. There is a few moments delay, so we'll hang tight for a minute. I think this is very interesting, and I think just as Carrie Draper mentioned in the introductory video, as we're working on so many different issues, if it's around food insecurity or other healthy eating, active living possibilities, that transportation is often that central intersection, just like one of your slides. So I know that that is something that we have been looking at a little bit more, and look forward to looking through your guidebook a little bit more closely.
Mobility is essential for participating in community life. I used to bring in, at my last job before I became a consultant, I would bring in people with visible and invisible disabilities to speak to bus drivers at all hands training sessions. And they talk about what it means to them to be able to ride, to get a ride to get to work, to shopping, to school, whatever it happens to be. You can't participate in community life if you can't get there. And it was an educational opportunity for the operators, because invisible disability, they don't know that the disability exists. So we had people explain, I have difficulty breathing or difficulty walking, but I don't need a cane. A little back and forth to familiarize. Just because you have a disability doesn't mean you should be walled off from community life. And that we have a lot of creative people who should be using their talents in the workplace if they can get there. Unfortunately, there's too many counties. There's 6, I think, counties in South Carolina that have nothing. They have no transit. They don't have taxis. They don't even have Uber or Lyft. So we really need to offer that mobility. And the other thing is, Affordable Care Act has a provision. If you have too many hospital readmissions within 90 days after discharge, the hospital gets dinged. Why do people get readmitted? Because they're not able to follow the directions. They can't get to the rehab appointments. They can't do the treatments. They can't get it to a store other than the dollar store that sells the salty snacks. If they had transportation for these things, they'd be in better health. They'd be in more control and able to maintain blood sugar, blood pressure, whatever the chronic condition they may have or be at risk at. So mobility really is key. I'm wondering how many of the audience work with folks in the transportation or public health field?
If folks would like to answer that question, you can use the Q&A to do so, and I will be able to pass that on. We do have one question regarding, you mentioned the use of EBT for transportation. Do you have examples from specific states that are doing that? And did they use Medicaid to start this, or was there some other way that they advocated for this?
No, Medicaid would be a customer. The Ohio has a NeoRide program, neoride.org. It's multi-state, has enabled properties mostly in Ohio, but also Michigan and Kentucky to buy account-based payment systems. Louisville, TARC in Louisville, Kentucky, launched one about a year ago. Chicago has the Ventra system, and it's backed by Visa, and that is account-based. And I think they've extended it to the Bubbler bike share. No, Bubbler is Milwaukee, excuse me, but whatever the Divvy, I think it's called in Chicago. That could be, once you have an account-based system, it's not restricted to the bus or the train. You can add on other participating ride providers, bike share, scooter share. I haven't seen that done yet, but it's been talked about. You can even work out a deal with Uber and Lyft. They're always, and certainly taxi companies. City of LA has a city ride program. It grew out of they subsidize rides for older adults and people with disabilities. Fairfax County, Virginia has done that too. So they're out there. They just need to be fattened up a little bit. The technology is actually easier than with Snap because we don't have to worry about riding on Cheetos.
We have a couple of more questions here, and we have a few more minutes. Do you think that there are any key points that should be highlighted when doing a food mapping project laid out with transit routes to encourage local transit departments to increase routes to the specific areas? You
can show on GIS, you can definitely measure the street mile radius from grocery stores that sell produce, and that'll highlight who's outside which are the food deserts. You can overlay the transit routes, as you mentioned, and see if they connect up and run through the food deserts or not. I would also add some factors to indicate population density in those food deserts, as well as income, average income in those census tracts. And it'll just highlight the need for it. I mean, if the food desert isn't somebody in an area where there's big fancy houses with horse lots in the back, not quite a priority. But for lower income neighborhoods, very important.
Do you have any examples of how healthcare has funded transportation projects?
Well, Medicaid, of course, has a non-emergency Medicaid transportation has been around for quite a while. A new player are a lot of managed care organizations and insurers are offering Medicare Advantage programs, and some of these pay for rides. They found it's cheaper just to pay for the ride so that the individual doesn't miss and become a no-show for a doctor wasting his time or her time, or for an MRI test wasting the time of the technicians working the equipment. Plus it results in better health outcomes. The data on the healthcare side is so much deeper than on us. We just know if we provided the ride or not. But we can merge this data. This is an area that needs some further research. On the Medicaid side, they do correlate. Did you ride that day? We have a transportation bill. Did you go to the doctor that day? We should have a medical bill. But it's easy to go a little bit beyond that. So you've got Ride Health, Round Trip, a couple other companies that sell their services to managed care providers and are very successful. And then they in turn match with ride providers in the locality to who can provide the trip for both wheelchair users and ambulatory people. It's just a good way to do business. We're really part of the healthcare infrastructure.
There is another, it's a question regarding if you're familiar with Ken Kolb's work in Greenville, that he's looked into how folks access grocery stores and that they tend to go once a month and use ride sharing networks. There is a link provided to a book.
Can you please share it with me? Because
Yes.
I can't see the Q&A. I'm working with a group just out in Greenville County. The focus is on the southern part, Fountain Inn. The project's called Carolina Rides Plus, and with the website PLUS instead of the plus sign, .org. And we are marrying human service and employer transportation along with healthcare. In other words, we'll take people to and from human service sites, people with developmental disabilities, to and from community-based employment. But a lot of these employers also offer low-wage job, industrial warehousing jobs, and can't fill them. And because they don't pay enough for someone to go get a car, especially these days, they're expensive, to get to and from work. These places are located on formerly vacant, undeveloped land. They're in opportunity zones. So transportation is a real issue, and employers are willing to subsidize those rides. And that's our vision. But adding in the food deserts and doing weekly grocery trips, which I have experience with, love to do it.